Maybe nobody's here yet. Okay, so it's letting people in now, Dr. Shoback. Can you get in?
Hello. Hello, if you're just joining us, we're actually getting prepped here with the doctor. So we'll be just a few minutes and then we'll have Barry take over and get us started.
Yes,
Okay.
I
Well, I gotta put her in as a panelist.
Mm-hmm. And we're still holding for the doctor to come on in just a minute. We're getting her screen pulled up. So for you guys that are waiting, we hope you had a great break. And it will be just a few minutes or a few seconds to get this set up. Just a few minutes.
Okay, both of them are in.
All right, very good.
Okay. Okay,
So,
Barry,
do
go
we have
ahead.
Dr. Shoback's screen is sharing.
Shall I?
there you
Welcome
go.
back.
Welcome, Dr. Shoback.
There you are. Hi.
Hi.
All right, so Barry, you take it away.
Welcome back, everyone. I hope you had a good morning so far. We are excited to welcome Dr. Shoback, who is from UCSF Endocrine and Research Unit. She's going to speak on the challenges and diagnosis of hypoparathyroidism, along with parathyroid PTH treatments. So as you know, you can enter any questions into the question and answer screen, and we will be taking a break midway through to answer any questions. So without further ado, here is the Dr. Shoback. Thank you, everyone.
Hi, everybody. Good morning, good afternoon. Barry, thank you very much for the nice introduction. It's a real pleasure to be with you, even in this kind of a format. So I'm really happy to be able to talk to you. I'm going to just share the screen and get these slides up, and then we'll go ahead. And I will try to stop periodically to take any questions the way we would if we were together. And, you know, if you have any, I think they have it set up for the chat function, and they will, they'll pose them as we go along. So feel free to put them in the chat, and the slides will be available to you. I've sent them in. So if you know, want them or want to make notes on them or something, they're going to be available. So what I want to do in the next 30 minutes or so is talk about how we as you know, endocrinologists and clinicians make the diagnosis of hypoparathyroidism, what you guys should know, because I know when I've been to the meetings in person, you all come up to me and tell me how sometimes hard things have been to get the diagnosis nailed down. So just kind of what you should know. And I know there's lots of new people, so you know, what you've been through probably is a pretty fresh experience, and some of the challenges that we face, because sometimes it's just not a simple slam dunk, as I think many of you in the audience know better than I do. So disclosures, right now I'm serving as a principal investigator on the Ascendis trial in the use of TransCon PTH in adults with hypoparathyroidism. Okay, so making the diagnosis of hypopara. What should you know as a patient or a family member or a parent? Okay, so I think first, really, what are the causes? Okay, what is this entity of hypoparathyroidism? Because sometimes it comes completely out of the blue and people have no idea. They've never heard the word even. Okay, so some of the causes. And then we as doctors, we often have what we call a clinical diagnosis. You know, like what does the patient have that he or she is experiencing clinically, you know, that they're complaining about? What organ systems aren't working right? And what are the complaints? And I'll go over some of the terminology we use there, because, you know, like we get into the habit of using, you know, medical terminology lingo, and I want to try to demystify a little bit of that if I can. Okay, so we'll talk about that, and then talk about the laboratory diagnosis, because we use a lot of lab tests in endocrinology. And this kind of condition is no different. So when you use lab tests, you need to know what's normal, what's abnormal, and unfortunately, what's in the gray area, because many times things land in that gray area. And then we have to use clinical judgment and then go back to the clinical diagnosis and so on and so forth. So it's an art. No imaging or pathology is involved. So there aren't a lot of scans that we do in diagnosis of hypopara. And then finally, what are the challenges? And we're going to go over this in some slides. And I just say right from the start, in medicine, a lot of things can look the same. One symptom can be due to a whole bunch of different causes. So we need to have both the clinical diagnosis up here and the laboratory diagnosis. And those things need to fit together and everything needs to align. And then it becomes a lot easier to make the diagnosis. Okay. So just quickly, so we have background and nobody's left in the dust here. We're talking about the parathyroid glands. Now this big butterfly kind of shaped thing is the thyroid. In the parathyroids, they're kind of misrepresented a little bit here, but they're in the back. Okay, and we typically have 4 of them, but that's what we're talking about. This is your trachea, your windpipe, and your larynx is right up here. Okay, and this is just taking a quick look at the parathyroid glands where they're located in the back. Each of us generally has 4, but there can be more than that, or there can be less than that. And they are tiny. They are busy little glands because the total amount of them in an adult is about 150 to 200 milligrams. This is tiny. So one gland on average weighs about 50 milligrams, and you can see this is a fraction of an ounce. So these are tiny, busy little glands. And really they only do one thing pretty much. They make parathyroid hormone. You'll see it abbreviated as PTH 1 to 84. And that just means the amino acids. It has 84 amino acids. So let's demystify that right off the bat. And PTH is essential for the health of like the entire body pretty much, but it's really important for the bones and the kidney. And it's really crucial for calcium balance. And every cell in the body needs calcium. Okay, let's not forget about the thyroid, because most of the time when we get together as a audience, I take a poll and you tell me like over half of you, sometimes 70, 80% are taking thyroid hormone. So that comes from the thyroid gland, much bigger than the parathyroids. And 2 hormones are made, a hormone called T4, thyroxine, and T3, triiodothyronine. This one is the precursor, or sometimes call it the prohormone for T3. And all the tissues in our body make their own T3 actually. The thyroid makes some, but the tissues make it. And they make it on the basis of what they need. And that's a good thing, because this is the most active form of the hormone that acts in each cell in our body. Okay, so most of it's made by the peripheral tissues and some is made by the thyroid, but that's what the thyroid does. So the parathyroid and the thyroid. Are there any questions before we move on to sort of definition and lab tests?
Yes, there's one question here. Is there research being done on muscle weakness issues even when calcium is managed through medication?
Yeah, it's a good question. And I would say I don't think there's actually a research study in that regard. Sometimes we pick up those symptoms when we talk to people, patients who have pretty stable calciums, but they're still having muscle symptoms. So I wish I could say there was a research study, but I have to tell you, I don't think there is. And some of that relates to, as you've already kind of heard, just a rare disease. And they're just, the research studies are few and far between. So it's an important question, no question.
And then one more question. If phosphates are normal on labs, do we need to do any testing to see if there's calcification in the brain or somewhere else?
Okay, I'll tell you what, we're going to get into phosphate in a little bit. Let's table that question for this moment, and then we'll get into it with the lab tests, and I'll make a note to answer the question about brain calcifications. Okay.
Thank you.
All righty. So what's the definition of hypopara? Okay, let's start with the definition because you gotta have a definition of something if you're gonna understand it, right? So it's either the absolute lack or it's just an inadequate amount of PTH 1 to 84 to maintain normal calcium, phosphorus, and mineral balance in our bodies. Okay, so that's it. It's pretty straightforward, right? So it's a lack or just not enough. Something you've got, but it's not enough. Okay, so what does PTH do in our bodies? So here it is right here, made by the parathyroids. Here they are in your neck. It goes to the kidney and bone, and it does all of these pretty important things. It'll raise 125 vitamin D levels, and I'll show you more about that in a moment. It'll regulate the turnover that goes on in bone, and I'll try to explain what that we mean by that. It's going to increase calcium reabsorption. Renal just means kidney, by the kidney. It's going to clear phosphorus out of the body through the kidney. And these actions of parathyroid hormone, this is what we depend on every single day, are going to maintain, they're going to raise the calcium and maintain it, and they're going to lower the phosphorus and maintain it. And they're going to maintain a good level of bone turnover so our bones are happy and our bodies are happy. When we haven't got parathyroid glands or we haven't got PTH or it's inadequate, you get hypopara. And then a whole bunch of things, just like what's normal over here, happen. Okay, the calcium goes down, the phosphate or the phosphorus goes up, the PTH levels are low, the calcium in the urine, particularly when we treat people with calcium, goes up, and bone turnover shuts down. Okay, so those are the key actions of PTH, the 4 key functions of PTH. So let's go into them because I think it helps us to understand the physiology and understand the labs when we understand the physiology. So the key functions. One is to maintain a good level of 125 vitamin D. What is that? Okay, so take a look over here on vitamin D metabolism. When we lie in the sun or go outside, sunlight causes our bodies to make this cholesterol compound, which can then be converted to vitamin D3, okay? Or we can take in vitamin D from our diet, okay? Either source goes to the liver. The liver makes this form of vitamin D called 25, just 25 by itself, 25 hydroxy vitamin D. Then that is like a storage form, and that goes to the kidney, and the kidney makes 125 vitamin D. Now, this particular step, this critical step right here, this one little critical step relies on having a good amount of PTH in our bodies, okay? And so what does vitamin D do in our bodies? It does a lot of things, but the key thing here is it acts on the intestine to bring about the absorption of calcium and phosphorus from the food that we eat or the supplements that we take, whatever it is, okay? 125 is essential for that. You see it's right here. It maintains calcium balance. Now, let's demystify a few more things here. 125 vitamin D is calcitriol, just another word for it, okay? And lots of you are taking calcitriol, so now you know exactly what it is. Another key function of PTH is to maintain a normal level of bone turnover. What is bone turnover? Well, if you look inside a bone, it's not just a big piece of cement. The bone is not inert, it's not dead. All of these are cells and very active little factories of hormones and calcium and phosphorus and really a lot of things. So I call the bone a treasure chest of calcium, phosphorus, growth factors, and hormones. And these are needed by places in your body. So when bone is turned over or metabolized or recycled or anything you want to call that, these important goodies, okay, come into the circulation, calcium, phosphorus, etc. And our tissues and our cells need them. So if the bone turnover isn't happening normally, our bodies are being deprived of some of the goodies that are in the bone, okay? And calcium is one of those very important substances in the bone, and it's there in huge quantities. So without PTH or not enough PTH, the bone can't release the calcium that the tissues and the bloodstream need, okay? So that's a key function of PTH that gets messed up when we don't have enough PTH. And then there's 2 important functions of PTH that act on our kidneys. One is to bring calcium back into the body. So that kind of seems counterintuitive, but think about it. At times when calcium is scarce, and that's like when you were asleep, when you're fasting, no food's coming in, no calcium's coming in, you're not taking your pills or your supplements. So the kidney, under the influence of PTH, can bring any calcium that it's about to excrete into the urine back into the body. So that's a reabsorption critical process. And then the other thing that the kidney does, very importantly, is it can clear phosphorus out of the body. Why that's important is that phosphorus comes in every day through our diet. And sometimes the intake is pretty high, and we don't want to put all that phosphorus in our bodies. We want to get rid of what our bodies don't need. So clearing phosphorus out of the body under the influence or the action of PTH is really important, action of PTH. So when there's not enough PTH, we get hypopara. And remember this little sort of figure I showed you a few slides back. What you see when you look at the blood tests is a low intact PTH level, or just a low PTH level. You see a low serum calcium level, and we'll get into more detail. We'll drill down on that. You'll see an elevated phosphorus level. You may see, but you might not get any blood tests to help you understand this, but you will have low bone turnover. And then because we give calcium back in one form or another, often you will see the urine calcium go too high. Okay, and that's generally because of our treatment. Usually in the initial phase of making the diagnosis of hypopara, the urinary calcium often is not terribly elevated. There's exceptions, but often not. So what are the causes? So in the adult, okay, and you guys know this because I bet the majority of you are post-surgical. These are the surgeries that can cause hypopara. Okay, but then the other important causes I've listed here, and there's a lot more detail that I'm sure other speakers in this conference will go over, but there are a number of, 10, 15 different genetic causes, okay? Then there's other causes, magnesium problems, magnesium depletion, or high magnesium levels. Sometimes that occurs, but it's pretty rare. And then autoimmune, which can be just autoimmune hypopara all by itself, or with other things, autoimmune adrenal disease, autoimmune thyroid disease, and so forth. So those are some of the other causes. And then again, really rare, the glands can get destroyed. Sometimes it's because iron deposits in them because people have had a lot of blood transfusions. Sometimes it's due to copper depositing, and that's a rare condition, really rare. Sometimes tumor in the neck can spread there and threaten the glands. And then sometimes even, and it's super rare again, I-131 therapy can damage the glands. And then there's a pretty big category. We're hoping to understand this better over time. We call it idiopathic. We don't know why. We don't know why you have it. Okay, so that's kind of just a bird's eye view of the causes. Okay, and many of you I know will be post-surgical, but then those who aren't always want to know, why do I have this? And so these are some of the causes. Okay. So what parts of the body can be affected? So now we're drilling down onto some of the clinical presentation and what we as doctors are looking for when we talk to somebody with a low blood calcium. So then the brain and the nervous system can be affected. Seizures can occur. Somebody already asked the question about calcifications in the brain. Sometimes there's movement problems, like almost like a Parkinson's picture in people. On the neuropsychiatric side, there can be anxiety and depression from the clinical consequences of hypopara. Sometimes the heart can get involved. Thankfully, it's rare, but sometimes the heart can get enlarged and not function properly. The eyes can develop cataracts or swelling. This just means swelling in the back of the eye. Sometimes the lungs and the larynx can go into spasm, and there can be throat tightness or wheezing. The kidney, really important. Sometimes there can be calcium deposits. That's what nephrocalcinosis means, calcium deposits in the kidney or kidney stones. And sometimes if the kidney is being affected by this condition, chronic kidney disease can develop. And then the peripheral nerves that go all the way through our bodies, sometimes people can have what are called paresthesias. That means the funny feelings or feeling numbness, tingling, unusual symptoms due to the nerves. And then muscle cramping and tetany. Tetany is like an involuntary contraction of the muscles. Okay, so muscle cramps and tetany. And I've put these red stars here. And again, you're going to get all these slides, so don't worry about writing any of this down. But these red stars are just some of the most common things that patients experience and they complain of and they notice. And sometimes it's every single day that there's a symptom there. So what are the main symptoms? When I'm interviewing a patient for the first time, I'm asking about everything, but what I'm really focusing on are you having tetany? Are the muscles contracting painfully? Any seizures or fits or convulsions? And there's lots of kinds of those that can happen. Anxiety, depression, poor memory, brain fog, okay? That's kind of a common symptom. The bronchospasm or wheezing I talked about, the laryngospasm or throat tightness or choking. Sometimes people have the muscle cramps. And then the paresthesias that I've already mentioned to you. And for some reason, the hands and the feet and around the mouth and the lips are places where people say, that's where I've got it. That's where I feel numbness. And then the kidney effects. And I call this the clinical picture. Okay, what are the symptoms that you're having? And I'm looking at all of that as I'm looking at the lab tests. Okay, so that's my clinical picture. So I want to turn now to the laboratory test for hypopara. Does anybody want to ask a question before we get into the lab about anything on the list of clinical signs and symptoms?
I think we'll just save all the questions till your scheduled break.
Okay, very good. Let's move on to the lab testing. So making the diagnosis and monitoring therapy, that's what we're going to look at. Again, these are busy slides, but let's take a look at what we do to make the diagnosis through the laboratory. We do a lot of blood tests. Everybody knows that because you're doing those blood tests when you come for your visits. But the key ones, I've put these big red arrows next to. The total calcium, and you always have to look at the normal range for the lab, and that's going to be low. Okay, that needs to be outside the normal range. Do you need to have an ionized calcium every time you get a total calcium? Generally, no. Okay, but that should be low also, and you usually don't need both. The albumin should be normal, and we often will look at that and look at the calcium in the context of the albumin. That's a protein in our blood. The phosphorus or phosphate, either one, they're kind of interchangeable. You see the normal range. That's going to be high, typically, in hypopara. Creatinine is a measure of kidney function, should be normal. Magnesium should be normal. And then the intact PTH. Intact just means 1 to 84. That's all that word means, okay? And there's going to be a bunch of normal ranges. I've just put one for some of the reference labs that I use in the clinic, but the normal ranges are going to vary from lab to lab. And in general, these levels are going to be low. So they're going to be below 15. They might be undetectable. It might say less than 5, okay? Or it might be 15 and the calcium is low, like the calcium's 6, and that's not enough PTH if the calcium is 6. So we use those together, and that's what we would call inappropriate. You might say, well, it's normal, but it's inappropriate because it should be high when you have a low calcium. And then the 25 hydroxy vitamin D should be normal in hypopara. So that's how we make the diagnosis. And these two tests are absolutely essential, okay? So all this inappropriate and low normal and all this other stuff, what does it mean? So this is a little chart that we use a lot in endocrinology when we look at the relationship between PTH. It's over here on the y-axis, okay? And here's your serum total calcium on the x-axis. And these little open blue squares down here in the corner, in the left corner, are patients with hypoparathyroidism, okay? So you can see the calcium's low and the PTH is either frankly low or it's touching this normal range, okay? But these folks with hypopara are not in this normal box, because if you have a low calcium like this, your PTH, if you're normal, should be way up here, okay? So that's the relationship. It's a very important relationship between calcium and PTH. So what are the challenges in diagnosing this condition? I've said some of them already. Patients should be frankly low or at the low end of normal. Let's say your level is 8.3 or 8.2. Is that normal? No, it's not normal, but it's at the low end of normal. And I would ask, if it's 8.2 or 8.3, do you feel anything is anything wrong? So we put the laboratory together with how the patient feels clinically, okay? Ionized calcium, not every lab offers it and not every lab does it well. So sometimes patients say, well, I want to get that done. And sometimes if I don't know that the lab is doing a good job with that or even offers it, I don't order that as my main test, just my own bias. Albumin, we often will do an albumin corrected total calcium when we make the measurement. So that's why albumin is measured. But if your albumin runs low, you might, want to be getting ionized calcium as the better test. For phosphorus, it's typically high, but in some people, depending on what your diet is, it might be normal. And again, depending on diet and other factors, it might be low. So it's not always, one thing, okay? Creatinine, again, should be normal. Magnesium should be normal, but it can be low in hypopara. So not everything, there are exceptions to every rule. And then we've talked about PTH, and you just need to look at the normal range for the lab and think about, we as physicians, we need to think carefully about what that PTH means in you. And again, the vitamin D should be normal. So here's a case that we had in the clinic last year. This is just to show you how these numbers land, and maybe your numbers are similar to this. So she was an 18-year-old college student who came to the ER who was having headaches, and she couldn't do her, college studies. Look at how low her calcium was, 4. Okay, you can see way outside the normal reference range. Here's her albumin, normal. Here's her ionized calcium, super low. Here's her magnesium, just at the bottom of the normal range, but okay. Look at that phosphorus, really high, okay? Creatinine, normal. PTH, we repeated it twice, it was undetectable, and you can see the normal range for the lab was different from what I've been showing you. That's what you have to pay attention to those things. Her 25 hydroxy vitamin D was a little bit low, but still it wouldn't explain all of this. This is hypopara. She was a little bit vitamin D insufficient, but she also had hypopara. And then her 125 vitamin D was kind of in the normal range. And we said, hey, do you have any other lab tests? She said, nope, I've never had a blood test done before. So that's what we have to go on. So some suggestions about lab tests and how you as a patient or you as a parent or as a caregiver can help with the diagnosis and treatment of hypopara. These are just some pieces of advice that I would give you. Keep track of your lab tests yourself and keep track of the treatment that you're getting when the blood tests were done. And I've put a little chart in here that I think would be a good one. If you're not doing this already, put it on your computer or your iPad or your phone and just chart with the date, any of these measurements that are done, the meds that you're taking at the time and how you feel. I mean, that's so valuable when you come to your clinic visit. Keep copies of your records, okay? And keep copies of your lab tests with, the records you keep of your health. I say old tests before you or your child got sick can be super helpful. Like we tried with the patient we just saw in the ER. Did you have any other lab tests? When did this start? What were your tests a year or 2, 3 years ago? Can be really helpful. And then old records. Lots of times we as physicians, it's hard for us to get your records unless you give permission. So get your old records if you can and keep copies of them so that when you change doctors, you can just say, here's a copy of my records. If you had surgery, get a copy of the pathology report and if you can, the operative report, and give that to your doctors. It's very helpful for us to review that. And then another thing is that more and more, particularly people who don't have post-surgical hypopara, get genetic testing. And I say, get a copy of that report. The tests change over time, their sophistication and sensitivity change, they improve. And the genes get added as we learn more about hypopara. And so what you had 5 years ago might be, I hate to say it, a little bit out of date. So testing once doesn't always end the matter. So get a copy of that report so that we're not wondering, oh, what was done 3 years ago, you know? I think it can be really helpful to have it. What other tests might be ordered? This might get to a little bit of the question that was asked about brain calcifications. So one of the tests we often follow is the calcium phosphate product. If it's high, it can give us a clue as to your risk for calcium deposits in places like the brain or kidney. If it's high chronically, do I order a brain scan or a CT scan on patients? Generally, no, because it's hard to get insurance to pay for those things. But if there's symptoms, anything going for brain or central nervous system symptoms, then I think a scan could certainly be in order. You'll see us look at eGFR. Here's what that stands for. It's just a measure of kidney function from the creatinine. The 24-hour urine, the much maligned 24-hour urine. There we're going to get a calcium and a creatinine. And there we're going to be asking the question, are you taking too much calcium or calcitriol? And then we often will use that if you're having a history of stones. The renal ultrasound or CT scan, we can look on those for kidney stones or calcium deposits or obstruction to the kidney if kidney function is reduced. And then other hormones, we might measure thyroid or adrenal function. We already talked about genetic testing. If it's non-surgical, we're going to be wondering, why do you have this? Ophthalmology exam, looking for cataracts and monitoring them and following them. Lots of times questions come up, should I be getting a bone scan or a DEXA scan every year? And it's important to know, not every year, and only if you're at risk. For example, if you're a postmenopausal woman with osteoporosis, or you might have osteoporosis, that's a situation where we're getting it. But just regular hypopara, you may not need it. And you likely do not need it every year. And then some of the lectures are going to talk about bone turnover markers. I would say those are not part of the usual testing that we do. If you're at risk and you might need treatment for osteoporosis, the doctor might want to get it, but infrequently, if ever at all. So these are just, again, demystifying some of the tests. So how frequently should all this stuff be done and measured and monitored and so forth? Well, thankfully, we have 2 published guidelines, and lots of times these are good to find a way to get into the hands of your endocrinologist. And I believe the Hypopara Association has both of these guidelines on the website. Okay, so this one is in the European Journal of Endocrinology in 2015, and that's from the European Society. And then the first international workshop published their guidelines in 2016 in the Journal of Clinical Endocrinology and Metabolism. And there's a brand new set that is going to come out in 2022. So we've got guidelines. And that is so helpful because doctors like to have, experts weigh in and give them advice on how to monitor things. Sorry for the busy slide, but this is kind of a summary of the European Society of Endocrinology guidelines for hypopara monitoring. So they say do the biochemical tests, okay, and I've listed them here, every 3 to 6 months. It's just a recommendation. Maybe you need it more frequently. But here's just a solid recommendation for endocrinologists if they're wondering. If you have symptoms, monitor those every 3 to 6 months. If a change in treatment has taken place, then you want to do monitoring either weekly or every other week until you're stable. Urinary calcium, we're going to do that once a year or every other year, depending on your particular situation. Imaging of the kidney, if you've got stones or if the serum creatinine, the measure of kidney function, increases, which means kidney function worsens. Clinical monitoring signs, symptoms regularly, okay? Check, that's what we call a checkup. How are you doing? What's going on? Bone mineral density, I've already said, that's the DEXA scan. We don't need to do that routinely, only if it's needed. From the other set of guidelines from the first international workshop, this is their table. So we've got lots of advice out there. They say do the biochemical test yearly or more frequently if the situation makes it appropriate. Do the urine calcium and creatinine annually or less frequently, again, as clinically indicated. And then these other studies as clinically indicated. Okay. And somebody asked the question about brain calcifications. What these guidelines say is, we don't know for sure. We can't recommend doing this once a year or every 2 years. You have to use clinical judgment, and we've already talked about it. Okay. And so these are some guidelines that are out there that are really good for endocrinologists to have on hand when they're taking care of you chronically for hypopara. So just to summarize, making the diagnosis of hypopara, the talk, we went over some of the most common causes in addition to post-surgical. We talked about what constitutes kind of a clinical diagnosis, the signs, the symptoms, the complaints, the issues, and so forth. And then we talked about what tests we use to make the laboratory diagnosis and what tests I recommend that you keep an eye on as you're being treated for this. We went over what's normal for these lab tests and what's abnormal for a standard reference lab, but you need to follow that closely with the lab your doctor is using. We talked about all the different tests that are the ones that are critical to have on hand and those that are less essential but can be helpful. Okay. And I talked to you about how to approach the lab testing results, how we look at them, and then how you should be kind of looking at them as you're tracking your progress with the condition. And I talked about some of the challenges in testing. Sometimes people are right on the borderline and we have to use clinical judgment. It's not clear cut. It's not black or white. It's gray. Okay. And there's some challenges involved with the testing. And then just, very, very small amount of information because they're very significant documents. We have two guidelines, published guidelines for the tests that should be due from, should be or can be considered to be done for monitoring and the frequency. Again, just some guidance for our physicians. So with that, I'll stop. I'll stop sharing if that makes sense, Barry, and
Yes.
we'll take questions.
Perfect. We have a bunch, both in the chat feature and in the Q&A. So I'm going to start with the Q&A questions. And someone asked, why do the parathyroid glands seem to work a little at times and barely at all at other times?
Yeah, and I think the question relates to patients who have hypoparathyroidism. And I don't think we have an answer. I'm going to tell you today, there's a lot of no answers to these good questions. Maybe the circumstances under which you find yourself there. So calcium is an important regulator of parathyroid hormone. Phosphorus is another one. Stress is another one. Catecholamines, kind of adrenaline is another. There's lots of things. Calcium's really important, but there's other things. And so maybe at a particular moment in time when the blood was taken, something else was driving a little bit of PTH to come out of the glands. But I agree with you. Sometimes patients with hypopara post a level of 3, 6, 10, sometimes 20. Does it change the diagnosis? Usually you take a bunch of measurements and you kind of make a decision based on a number of measurements. I should have said that before. It's never made on one measurement.
Okay. Becky asked, she said there are some new drugs up and coming that have a base of PTH 1 to 34. For those of us on Natpara PTH 1 to 84, what is the difference overall? What do the extra 50 amino acids add to our health if taking the PTH 1 through 84?
Yeah, it's another great question. And we've been trying to solve that one for, I'd say, 40 years. A lot of us sort of think that the rest of that molecule, it's a good question, Becky, the rest of that molecule is doing something else. Maybe there's a separate receptor for it. That's been one idea that's out there. Maybe it allows the hormone to bind for a longer time to the receptor than 1 to 34. Boy, it's an unanswered question. Some people think that there's a receptor in bone for that part of the molecule. I don't think we know. We just don't know.
Okay. For people on conventional treatment, is it better for your kidneys to take calcium supplements or instead get calcium through dairy products? Should I be worried about the amount of phosphorus present in dairy products? How bioavailable is the phosphorus in dairy products? I have heard that calcium binds the phosphorus.
Yes, so she's got some of that, some of that I hope we'll cover in the next lecture on treatment. But you're totally right. Dairy products are a good source of calcium. However, they also bring phosphorus into the body. And if your parathyroids were working, they would get rid of that phosphorus through the kidney. But when they're not working, that phosphorus builds up and you get the high phosphorus. And with a calcium level that's even normal, it's the product gets too high and it goes into the soft tissue. So should we be worried? Dairy products aren't the best source of calcium with hypopara because of the phosphorus, okay? Otherwise, the diet is a great way. If you can get it through things that are fortified with calcium, that it's not calcium and phosphorus the way it is in dairy, that's okay. It's a great way to get it. So I'm all in favor of dairy, but diet, excuse me, I should say diet. Slip of the tongue there. I'm all in favor of the diet being a source, but I think you have to be thoughtful about the phosphorus.
Okay. Someone asked, does hypoparathyroidism have an effect on thyroid levels or vice versa?
Not so much. Good question. Not so much that either of them influence the other in a big way, but the treatment that you take for hypopara influences if you're taking treatment for hypothyroidism because of the absorption of the thyroid hormone. So that's an important interaction if you're taking both. If you have both hypopara and hypothyroid, you have to really be very careful about how you take your medications.
Okay. And Mary asked if PTH is needed to convert 25 vitamin D to 125 vitamin D. Why aren't 125 vitamin D levels low in hypopara?
Okay, Mary, sometimes they are. And if you think about that nice gal that I presented to you from the emergency room, I said to you her 125 D level was 33 or something, but her calcium was rock bottom, right? So her 125 probably should have been 100. So sometimes they are, and you could almost say, I kept it, I didn't get into it, but when I reviewed those numbers, I said to the fellow, hey, that's normal, but that's not normal for a calcium of 4.4. So that's the gray. Okay, we're in the gray now.
Okay. Ellen wanted to know, with the lack of efficient bone turnover, is bone healing after a total knee replacement a concern?
Oh, it's a good question. I think for the most part, we don't have so many problems with healing post things like joint replacements and so forth. And maybe part of the reason for that is that when they put that, when they put that new joint in there, they get that bone stimulated, and locally it's doing, it's repairing, and it's, we call it osseous integration. It's integrating into that bone because it's a bit of a traumatic thing, right? And the bone has many ways to, modulate turnover. PTH is one of the most important, but it's not the only one.
Okay. Why can regular calcium be normal, but ionized calcium be low?
Okay. So sometimes that happens when there are abnormalities in proteins in the body, because when we look at the total calcium, it's the ionized calcium, it's the calcium complex, and it's the albumin. So there's sort of three parts to that. So total might look okay because the albumin bound calcium is higher than it normally is. And then the ionized is lower. So it's the total reflects three, we call them pools of calcium. And there can be a imbalance in those pools. So you can sometimes get that.
Okay, and Jerry would like to know, can low calcium cause hypertension?
Low calcium, not so much, not so much. What is known about hypertension or blood pressure and calcium is that the high blood calcium is often associated with a higher blood pressure.
Now, Kimberly would like to know, are there reasons you wouldn't treat with diuretics?
We have to have, the main thing we need to do first is make sure there's a reason to treat with a diuretic. Diuretics have quite a few side effects, and if you don't need them, you don't want to be on them. They take fluid, they take salt out of the body and potassium and so forth. So if you don't need a diuretic, and I'll cover thiazide diuretics in the next talk, you don't want to be taking it.
Hassan wants to know, is losing hair related to hypopara?
A lot of patients ask me that. I have not seen a heck of a lot on that particular topic in the literature, but I do think that if there's anything wrong with your hormone system, now this is a bit of a generalization, but if there's something wrong with your hormones, often the hair is affected. And we certainly know that vitamin D receptors are very active in hair follicles and are very, very important. And so I wouldn't be surprised, and mice for sure, oh my gosh. So I wouldn't be surprised. And actually there's a rare human disease of the vitamin D receptor, vitamin D dependent rickets type 2, I believe it is, or whatever, where the vitamin D receptor is abnormal. And those people often have no hair on their heads. We call it alopecia. So yes, I think that both vitamin D, calcium are important for hair.
And someone wanted to know, is hearing loss related to hypopara?
Hearing loss, like post-surgical, I would say no, not really. There is a genetic form of hypopara where hearing loss can be present along with hypopara. So if someone has hearing loss and hypopara and it's not genetic, that would be a reason to get genetic testing to confirm that diagnosis.
Okay. Phyllis wants to know, does hypopara alter urine and body pH? How does it make it more acidic? And if so, how can we modify that? And does the body pH affect how TransCon PTH will work?
The last question, I don't know the answer to. That's easy for me to answer. I don't know. Maybe one of the doctors working on the TransCon study can tell you whether that amount of pH change is going to affect it. You know something? I don't think so, because we're giving TransCon PTH to people with hypopara and we're looking at the responses. So I'd say that if there's a subtle effect, it's getting overcome and we're seeing effectiveness. And I couldn't participate yesterday, but I would bet that they showed you some data on TransCon PTH showing that it does work. So I think somehow we're overcoming it. The other question relates to, are there changes in our own body's pH with hypopara? And I would say that the changes, if anything, have got to be pretty subtle. When you have too much PTH, you tend to be a little bit acidotic, but not everybody is. It's kind of one of those minor things. And so if you don't have enough, maybe you're a little bit on the other side, but I would say not a big effect on acid-base balance.
Okay, and it seems doctors prefer to keep hypopara patients' calcium levels on the low end of normal to prevent kidney stones. Does long-term low-level calcium impact other parts of your body, like joint degeneration? Are gallstones a product of taking too much calcium?
Not regarding the gallstones, not that I know of, okay? Does chronically low sort of borderline, that 8.3, 8.4, 8.5, right at the borderline of the lower end of normal, is that a bad thing for other tissues in the body? Sometimes I think it is for certain people. Sometimes I think it does lead them to have just not perfect, brain function and so forth. They need a little bit more. But you're right. We have all been kind of trained to kind of aim for that level, because when we aim for a higher level, oftentimes the calcium spills over into the urine, calcium, kidney stones form, kidney function gets, affected. And so we are trying to do this balancing act between keeping you happy and feeling well and not having damage to the kidneys.
That brings me to Heather's question. She says that she has chronic kidney disease stage 3. And since going back onto calcitrol after Natpara was pulled, my kidneys have gotten worse. I am now on potassium citrate to help bind the extra calcium that I am spilling. Lots of kidney stones in both kidneys.
I'm sorry to hear that. I do know that it is a difficult balance with conventional therapy in some people. Some people, it's enough, it's fine, it works beautifully, and they don't even want to come to the office every 6 months. In other people, it doesn't. It's a much more difficult proposition to get it right, and many times we end up with calciums in the urine that are just too high. I agree. And then once the stones form, getting them out of there is not the easiest thing, and dissolving them in place is not very easy. So it does become a very difficult problem. And either from those stones or from the local damage that they can cause, sometimes chronic kidney disease can result. So it's definitely something that we worry a lot about in treating hypopara. Yeah.
Okay, and Becky wants to know which bone turnover marker labs should we get?
I gave you my bias on that, Becky. My feeling is that we shouldn't be getting too many bone turnover markers at all. We do a lot of lab tests, there's no question, and we spend a lot of lab money. And the bone turnover markers might be useful to your endocrinologist if, for example, you're postmenopausal, you might have osteoporosis, you might be considering therapy for osteoporosis, or potentially, and I just say potentially because we don't know how, the guidelines will be revised once other forms of parathyroid hormone, for example, are widely available. You could argue that maybe in the beginning of treating somebody with a new form of parathyroid hormone, you might want to get a bone turnover marker. But I think right now it would be premature for me to tell you that you need to do this one, and this one every 6 months. I'm not going to say that because I think we need to have a little bit more information about what's necessary, because we already run a lot of blood tests.
Okay, I'm going to just ask one more question, and then if you want to proceed to the next part of your presentation. Do you recommend phosphorus binder for a patient the patient is a child with genetic primary hypoparathyroidism?
That's a good question and a tough question. And I'm going to talk about phosphate binders in the next talk, not a lot, just a little. And I'm going to put down that question about, and I'll try to, when we hit that slide, a child with genetic hypopara, okay? I will try to make some comments on that when we get to it, okay?
Okay, and just a comment from Kathy. She wanted to thank you for encouraging us and your patients to track their labs. When she was applying for disability, this was extremely important. She kept a chart with her labs and she graphed them to make a move of what's happening with her disease. And a lot of people are just saying thank you for your expertise. So thank you, Dr. Shoback.
Sure. My pleasure. Okay. Do we
All right,
want
so now,
Barry?
do you want to do your next part of the presentation at this time, or do you want to answer a few more questions?
Or do you need a 5-minute break? Are you good to keep going?
Why don't we take the 5-minute break for a couple sips of water, and
Yep.
then get the other presentation ready, and just start right at the top of the hour. Does that sound okay?
Okay,
Perfect.
sounds
Great.
great.
Everybody, for the ease of things, just leave your thing logged in so that we don't lose the session and have any problems. And for the presenters, you can just put yourself on mute, and then we'll come back in 5 minutes.
Thank you.
Shall I do the screen share, Barry?
Yes, I'm going to just reintroduce you in 1 second. I'm just going to wait till the top of the hour, which is right now. All right, so welcome back, everyone. We're going to have Dr. Shoback now present on conventional treatment with its challenges. So welcome back, Dr. Shoback, and welcome back, everyone. Again, we will ask as many questions as we can when her presentation is finished. Thank you so much.
Okay, you're welcome. Thanks for coming back, everybody. So we get to talk about conventional treatment for hypopara and really how to take care of yourself, because we all know that you guys do the main work in taking care of yourself. We're just the quarterbacking here. So what we're going to talk about are how to take the medications, calcium, the vitamin D forms that people often take, magnesium, mention thiazide diuretics a little bit, mention parathyroid hormone replacement, just one slide, but you're going to have a whole talk on it. I'm going to talk about thyroid hormones just very briefly because so many people with hypopara are taking them and it's important. And then the drugs that may interact with medications for hypopara. Okay, so the goals of treating them, sort of the first steps are to get that calcium at the low end of the normal range. Right around here is where we're shooting for. We want the serum magnesium to be in the normal range, and we want a calcium phosphate product to just simple multiplication, less than 55. So those are sort of our first 3 steps. And we're trying to avoid a high urinary calcium because of the kidney complications that occur. And just I put this in green to highlight the word that you often will hear is hypercalciuria, okay, or hypercalciuria. We'll kind of hear that, people, and that means high urinary calcium. Okay, so why are we doing all of this, or why is it so important to avoid a high calcium phosphorus product or a high phosphorus? Because we want to prevent calcium phosphorus deposits as salts in tissues where we don't want them: the heart, the kidneys, the eyes, cataracts, the brain, the blood vessels, and so forth. Because at the end of the day, those calcifications are probably associated with long-term complications in these different organs. And so the other very big goal of all of this treatment and focus on these biochemical parameters is we hope that if we can get those as normal and as close to normal as possible, that you'll feel well, that it'll improve well-being. Okay, so let's start with these medications, and I'm going to kind of run through fairly quickly all of these different medications. So let's start with calcium supplements. So here are just several that are on the market, and you may recognize ones that you take now or have taken, okay, and the names of them, okay. Generally, we're talking about calcium carbonate or calcium citrate, okay? And what are the pros and cons of one versus the other? Well, the citrate is better absorbed in people who have low stomach acid. Older people, anybody taking proton pump inhibitors or medications for reflux where the acid in the stomach is being affected, citrate is better than carbonate in those situations because it's easier to absorb. If you're taking calcium carbonate, ideally, it should be taken with meals because that's when acid is produced and it'll get absorbed there. And the other thing I find is that people always say to me, I can't swallow that pill, I can't swallow that pill. There are lots of liquid calcium supplements. You've got to hunt them down a little bit, but they're available on Amazon, they're available on Costco. And so calcium supplements in liquid form are also available, and that might just do the trick for you. So look around. So the amount that you need with hypopara is going to vary. 1 to 3 grams, hey, that's kind of average, but there's plenty of people that take more and some take less. We usually dose it 2 to 4 times a day, okay? And that's important, and you'll see why in a moment. So a few more things about calcium. Our gut can't really absorb more than 500 milligrams presented to it at any one moment, okay? So if you're saying I take my 1200 milligrams right after breakfast, that's not gonna work very well because your body can't absorb that much at once, okay? So you wanna spread it out, okay? And the amount that you absorb from a big dose of calcium or even a modest dose of calcium, and is going to vary from one person to the next. But here's the surprise. It's not 100%. You're going to absorb something in the 20 to 30 to 35% of what you take in. So you say, I just took 500 milligrams of calcium. Where did it go? Well, you might only absorb 100 milligrams of that, okay? And then in terms of side effects, calcium, sometimes it's unpleasant to take. It has an unpleasant taste, but the main potential side effect is people complain of constipation. So one thing I want to try to see if we can teach here and you feel comfortable with is the difference between the milligrams of the calcium salt and the milligrams of elemental calcium in the tablet. And this can get confusing because it's different. For sort of calcium carbonate, sort of putting it in plain English, it's two things. It's calcium and it's carbonate. And 40% of it is calcium and the other 60% is carbonate. So if you look at your label and it says 1,250 milligrams or in each pill of calcium carbonate, there are 500 milligrams of calcium there. The rest is carbonate. So you got to look at your labels, take a picture of them if your doctor's, torturing you with what are you taking, okay? And then the other thing I'm learning, okay, and I'm teaching my patients is look at that label for what is the serving size, because you can get a big surprise. Sometimes it'll say, patients will come to me and they'll say, I'm taking 1,000 3 times a day. And we look at the label and the label says the serving size is 4 tablets. Well, how many tablets are you taking each time you take it? And they're taking 1 tablet, okay? So the serving size may say 3 tablets, 4 tablets, and then the amount of calcium has to be divided by the number of tablets, and then you have to figure out what you're taking. So pay attention to what's on the label and this thing called the serving size. It trips me up plenty of times. Just an example, another example, Oscal 500. That's a typical branded calcium out there. 1,250 milligrams of calcium carbonate, 500 of calcium. So you tell your endocrinologist, I am taking 500 milligrams of elemental calcium 3 times a day. And that's how we dose it. We don't dose it by the total salt. We dose it by the total amount of elemental calcium. So that's carbonate, okay, plain English. Citrate, it's only 21% calcium by weight. The rest is citrate. And that one, I already told you that you don't need acid to get absorbed. So this one you can take any time of the day. You can wake up in the middle of the night and take it, with nothing in your stomach, okay? And it should be pretty well absorbed. And this is just another way to think about it. Here's your pill, and only 40% is calcium. The rest is carbonate, and same with the citrate, 21%. Okay, it's just a way to think about when your doctor says to you, how much calcium are you taking? You need to say, okay, elemental calcium, I'm taking 500 3 times a day. Okay. And we had some questions about diet, and I'm certainly no dietitian or diet expert, but there are plenty of good websites. Here's one from the USDA, and you can get of standard foods, you can get, how much calcium is in the foods. And here's a fortified, calcium total. One bowl gives 1,000. Okay, so you can get calcium through your diet, and they're just showing you here some of the different ways to get it. Okay, so read the labels on foods. Most of them now that are calcium, well, all of them that are calcium fortified should have the amount of calcium per serving size. Here's a nice one, the string cheese, just an ounce of it, 200 milligrams of calcium. So there's lots of ways to get it, almonds, etc. Okay. All right, now some important things, just kind of tips I want to give you. Don't switch the brands of calcium without talking it over with your doctor if you have hypopara. If it's an osteoporosis situation for other patients, it's not as critical, but here calcium is an incredibly critical part of your regimen. So don't just buy any brand and assume it's the same. Be thoughtful and careful about it. And I think just all of you know that. If you're not sure, you can't find the brand that you've been taking when you go to buy it in the pharmacy, talk to the pharmacist, okay? These people are great resources. They have a lot of information. And sometimes the labels don't have what you want to know on them, and the pharmacist can can look up or show you how to look up or help you look up what exactly is in that supplement you're thinking you're going to buy. If you make a big change in the supplements, like you used to be able to take calcium citrate, now you're taking carbonate, or the vice versa, or completely different formulations, get the calcium checked to make sure that you're still okay. You're not hyper and you're not hypo, okay? And the labels are tricky, as I've already shown you. And then either bring the meds to the appointment or take a picture of them and have them on your phone so that you can go over exactly what you're taking. Okay, so that's what I wanted to say about calcium. Let's move on quickly to vitamin D. And I've already talked a little bit, we've already reviewed sort of the metabolism of vitamin D in our bodies. But when you look at labels, you're going to see ergocalciferol, cholecalciferol. What are these things? So ergo is just convention, it's vitamin D2. Chole is vitamin D3. Okay, they're roughly equal in potency, roughly. Okay, and then there's 125 dihydroxy vitamin D, or calcitriol. We've already talked about that one a little bit. We use that in hypopara a lot in the United States. In Europe, they use 1-alpha calcidol. Okay, it's just a different form of active vitamin D, and our bodies activate it, and so it's essentially interchangeable except for different dosing with 125. So we already talked about vitamin D being made in the skin. That's not a good way to treat hypopara, to keep getting sunburns or anything like that. I'm not saying that, but just to remind you that we have the capacity to make it in our bodies. And you also eat it in foods that are supplemented with it. It's almost always, remember, because sometimes we'll say, well, how much vitamin D are you taking? And people don't realize lots of multivitamins now have fairly substantial amounts of vitamin D. So look at the label of a multivitamin you might be taking. If you say, I go out in the sun every day and I'm vitamin D deficient, if you're putting sunblock on your skin, and that is recommended to prevent skin cancer, you can block, almost all the vitamin D production by the skin with sunblock. So keep that in mind. Like I said, vitamin D2 and vitamin D3 are roughly interchangeable. One's a plant form, that's D2. One's an animal form. When you take these, particularly in high doses, here I believe is 5,000 international units in that tablet. When you're taking it in fairly high doses, it stays in the body for a long time. Okay, so in 1 or 2 days, not much is going to happen if you take too much of it. So that's why we want to be careful. And the doses that people take with hypopara, they might just take enough, like for the general population. Maybe you're just taking 800 international units. If you're a person with hypopara who's using one of these forms of vitamin D instead of calcitriol, you might be taking 50,000 units a day, and that might be right for you. But the dosages are going to vary quite a bit. We use these lower doses, 800, 1,000, 2,000, to replace the stores of vitamin D in our body when you have a vitamin D deficiency or when you have what's called vitamin D insufficiency. And at those low doses, you're not going to get vitamin D toxicity, okay? But at these high doses, we have to be really careful, okay? Because they can be used to treat hypopara, and some of you may be on them, but you can get toxic with those high doses. So this is a broad range. I've already told you about calcitriol. It's the activated form of vitamin D, and it works on the intestine to bring calcium in from our food and also phosphorus. Okay, so remember, the more calcitriol you're taking, it's going to raise the calcium, yes, but it's also going to raise the phosphorus level. And the doses, like calcium, the doses you take are going to vary a lot. And in hypopara, oftentimes these low doses aren't enough. You have to go to higher doses. So it can vary to up to 2 micrograms per day. Remember, that word is micro here, not milligrams. Okay. And then this one, in contrast to D2 or D3, is short. It has a short onset of action and offset of action. So if we say, okay, take that 3 times a day and it's too much, we can easily make a change. If we overshoot, we can say, okay, just lower the dose for 2 or 3 days and then we'll check your blood tests and we'll start again at a lower dose. You can do that with calcitriol. That's why we like it. often better than D2 or D3. Okay. Now, I know vitamin D gets confusing fast, but the other form that you'll hear about is 25-hydroxy, and that's a blood test, okay? We've already talked about it, but it's kind of a way to tell, are you vitamin D deficient or insufficient, or are you vitamin D sufficient, okay? So it tells us about your overall vitamin D stores and what's on board, okay? And it's an integrator of what you take in, what your body makes, and how much is stored in the body, okay? And there are times when the levels can get high if you're taking vitamin D to control your calcium. If it's just vitamin D to keep the tank full, the levels should be within the normal range. So you have to talk to your doctor if you're using the high doses about what your level is. Let's move on to magnesium, okay? And normally when we're together, I always ask who's taking magnesium, and usually there's a good solid 30% of the group that's taking some magnesium. So why might you need magnesium if you have hypopara? Well, magnesium is the cousin of calcium, if you will. Your muscles, your heart, your brain, your nerves, everybody needs magnesium to be healthy. But you need some parathyroid hormone to keep magnesium in the body. And many people with hypopara often need to be given extra magnesium. And then sometimes if your intestine isn't working right, or you're having diarrhea or something like that, magnesium may be lost in that way. So periodically we recommend that you get blood tests for magnesium to just make sure it stays normal. And then the funny thing here is that some of the same symptoms of a low calcium, the tetany, the muscle cramps, the funny sensations, numbness, tingling, some of those same symptoms can be caused by low magnesium. It's the cousin of calcium. So these are two forms of magnesium supplements that people with hypopara often take. Magnesium oxide, it's going to give you, you can take a couple tablets each day, but make sure that your doctor knows you're taking it and the blood tests are checked. Because if kidney function isn't normal, sometimes the magnesium can build up in the body. Magnesium chloride is another form. It's got less per tablet usually. So people often take magnesium oxide. Let's turn to the thiazide diuretics. There was a question in the last session about thiazides. So there we're usually referring to hydrochlorothiazide or chlorthalidone. Those are the two most common thiazide diuretics that we use in the US. We use those in hypopara to lower the level of calcium in the urine. And for that to work, okay, you've got to combine it with a low salt diet, okay? So remember that if you are having a high calcium in the urine, your doctor wants to put you on a thiazide, ask to talk to a dietitian so you can go over the salt in your diet so you can get that low so this thiazide is going to work. What are some of the side effects? And this is why we don't give thiazides to everybody like they're, candy, okay? They are going to increase urination, they're going to increase thirst, they can lower the blood potassium level. You may need to take a potassium supplement. You definitely need to have that level checked. They may lower the blood pressure, and sometimes they lower it too much, and people get low blood pressure and get dizzy or even pass out. So there's a fair number of side effects, although they can work to lower the urinary calcium. And sometimes you have to just put up with some of those in order to get that done. Okay, let's turn to the phosphate binders. And I know there was a question, and we'll try to work on that one as we talk about these. Sometimes, and it's not common, they're not used very often, but sometimes they're prescribed if the serum phosphorus level is just too high and you can't lower it with diet. We usually start with working on the diet, try to get the phosphorus level low through dietary interventions, okay? And this is the level, these are the levels we're shooting for, okay? And so the phosphate binder, these are medicines that bind the phosphorus in the gut coming in from the food that you eat so that it doesn't get into the blood, okay? It gets bound and it's excreted when you have a bowel movement, okay? So we always combine it with the low phosphorus diet, because if you don't, you can just raise the phosphorus from what you're eating, okay? And I think it's a very good idea to talk to a nutritionist or a dietitian If your phosphorus is high and you want to modify your diet, it's a good idea to talk to a professional because it's not the easiest thing to fix just by, having fewer, hamburgers or something. Okay. So the phosphate binders, this is a picture of just one of them. They're given with meals because that's when the phosphorus is coming in. Here are some of them: sevelamer, lanthanum. Calcium carbonate's a phosphorus binder, and calcium acetate is a phosphorus binder. And this is one that's often used in patients with kidney disease. These are also used there. And you want to follow the serum phosphorus level. And the goal is to get that product less than 55. We've talked about that already. So do we give this? So somebody asked a question in the last talk. I think it was a parent who said, I have a child with genetic hypopara with a high phosphate. I will not answer that question about what you should do. I think you should ask your pediatric endocrinologist or your pediatrician, because phosphorus levels in children are higher than adults. And we need to make sure that the level that that child is going to have is the right level for him or her at the age that they are. So I would talk that over very carefully with the pediatric endocrinologist or pediatrician. But we don't use them all that much. We work on the diet, okay? All right, let's turn to PTH, and I'm not going to say much because Dr. Khan has a talk that she's already recorded for you on PTH. But there's, as has already been said, there's 2 forms of PTH that have been used in hypopara. And PTH, people have already talked about Forteo. This is PTH 1 to 34, the first 34 amino acids of PTH. It's also called teriparatide. Although people with hypopara take it, it isn't FDA approved for that indication. And so we sometimes have pushback from the insurance companies to get it for treating people with hypopara. PTH 1 to 84, it's the whole thing right here. It is NatPara, and it's on recall. It's only available through this special use program, which most people aren't on, but that's what we're talking about. These are the 2 forms of PTH that are used, have been used and tested, and her talk will go over it. Just a word or two about PTH replacement therapy, which is what we're doing with these injections. There have been a couple of clinical trials, at least 3, that have studied, PTH 1 to 84 taken as a daily injection. And these trials all show that you can lower the amount of calcium supplements to a very low level and calcitriol and maintain the blood calcium levels in the target range. Many of you know that NatPara, or 1 to 84, was approved in 2015 for hypopara, but then it was recalled from the market in 2019, and it's not yet available. When it was available, there were 4 different doses that were available, and I've already mentioned the special use program. Very few patients are on this. This is just the pen for the 50 microgram dose, and as I've said, Dr. Khan is going to give a lecture on PTH replacement. So monitoring treatment for hypopara. I think it always really, we sometimes forget, we think maybe we need to have like a big sophisticated spreadsheet. I always start with, how do you feel? What symptoms are you having? Are you having symptoms of hypopara? Are you having symptoms of a low calcium or symptoms of a high calcium? And so I put together 2 lists here, and we've kind of gone over the ones for hypocalcemia in the last lecture, but the tetany, the involuntary muscle contractions that are painful, the muscle cramps and spasms and twitching, these are all part of, severe hypocalcemia, the wheezing and the throat tightness, the memory changes, sometimes palpitations people have, sometimes they have belly cramps, numbness and tingling around the mouth and the hands, just feeling poorly, low energy. And then we don't want anybody to have a seizure or go into a coma, but that would be kind of way, way, way far gone. So these are the symptoms, and think about them when you're kind of thinking about how the therapy that you're undergoing is working. Have you got any of these symptoms that are part of hypo? And then if your therapy is sort of overdoing it, if you've become hypercalcemic, these are some of the symptoms. And you can see like sort of fatigue and poor energy, it's the same, okay? Poor concentration and memory, it's the same with hypo and hyper. That's why the clinical part of it has a lot of overlap and the gray zone. But these are the symptoms that we're paying attention to when we're thinking, am I treating with enough medicine, or am I giving too much medicine? And then I like to ask, okay, if you were feeling poorly and maybe your muscles were hurting or something, if you took an extra calcium or you took an extra calcitriol, did things get better? In other words, did calcium improve any of that? So I always start with how you're feeling and what the symptoms are like. And then the lab tests. And I've already told you, like a lot of the things I really strongly believe. Keep copies. You want to track your calcium and your phosphorus and your creatinine as a measure of kidney function. And periodically, your doctor should be checking your urinary calcium. And if you're taking vitamin D, or really just the general health of anybody with hypopara, a periodic check of that vitamin D store, and then magnesium. When you dose adjust any of the medications, usually we wait a week or 2 weeks before checking the labs. And you can do it more frequently if the numbers are unstable, but that's often what we do, 1 to 2 weeks. And then some of the other tests for monitoring treatment would be the kidney ultrasound. Sometimes we do a CT scan of the kidneys. You don't want, that's radiation, so you don't want to do that a lot. The ultrasound would be better, but sometimes we do periodically do a CT scan of the kidneys, and then an eye exam for looking for cataracts. Okay, so that's monitoring treatment. Let's talk just very briefly about thyroid hormones, because often about 70% of the audience is taking thyroid hormones as well. Okay. So many times we as endocrinologists will say, the first thing I want you to do in the morning is to take your thyroid hormone. Okay. And then don't take anything for at least 30 minutes and take it with a plain glass of water. Okay. And so those are kind of like the first things we tell you. So most of what's going to get absorbed is absorbed in that 30 minutes. But to get full absorption of whatever you're going to absorb, it actually takes 3 hours. But we usually will temporize and say, if you can keep an empty stomach for 30 minutes after you wake up, after you've taken your thyroid hormone, that's pretty good. So you don't absorb all of it, like calcium, you're absorbing more here, but not all, 60 to 80%. Again, the empty stomach. And then for the best absorption, some acid is needed in the stomach. And then we ask you to take it 30 minutes before breakfast at a minimum. And if you can, 60 minutes is even better. And you want to take your thyroxine as far away from the calcium as you can. In other words, don't take a big handful of calcium and put your thyroxine in there and take it all at once, because you're not going to absorb the thyroxine. Okay. And then sometimes it's a mystery, like how do you come up with the dose? And I just put this table in here so that you know that your doctor can look these tables up. I've given you the reference. Children need more, okay? And we base it on the weight in kilograms. Adolescents need less than children, but still more than adults. And adults, you can see right here, 1.5 micrograms per kilogram, or 0.7 micrograms per pound. When you get older, you often need less. And when you're pregnant, you need more. So there's lots of adjusting here that often needs to be done, depending on, age and pregnancy and things like that. And also the thyroid disease that you've had. If you had your entire thyroid removed, you're going to need more than the person who's had a partial thyroidectomy, okay? And then sometimes the target for the TSH level, which is the level that we monitor most closely in people taking thyroxine, we often are trying to get the TSH into a certain range if you've had thyroid cancer. So you need to know what that is, and your doctor will know what it is. And so you might say, I need to be between 0.5 and 2. So 3, 4, or 5 is not good for me. And that's right. Okay. So we need to measure the T4 and the TSH periodically and get it into the target range for you, depending on your condition. Okay. So we're not going to go into every single brand that's out there for T4. You can see there's lots of them now, and there's generic formulations and so forth. But my first sort of rule number 1 is don't just get whatever they give you, okay? stay with the same brand. And that's not because have brand loyalty or something. It's just that there are slightly different amounts of hormone in each one of these tablets. And when you switch the brands, you may absorb one versus the other differently. And then we have to completely, change your the dose of your supplements, and you have to get blood tests done and frequency and so forth. So just, don't let your pharmacist just change the brands. Ask for the same brand, okay? So you don't have to keep getting blood tests just because no one paid attention to the staying with the same brand, okay? So drug interactions, that's important when you're taking medications. What are some of the interactions between drugs that other doctors are going to give you? So though there's quite a few medications that can either interfere with calcium handling by the body or calcium absorption. So diuretics, if your doctor says, hey, I want to put you on Lasix because you have heart failure or something like that, remember that if you have hypopara, that's going to lead to calcium loss by the kidney. And so you're probably going to need more calcium or more calcitriol or more of both. If they're going to put you on a thiazide and you haven't been taking a thiazide, that's going to decrease the calcium in the urine, and it may raise the blood calcium. So that's going to have an effect. Prednisone. Prednisone is going to block some of the actions of vitamin D in the gut and the intestine. So you could become hypocalcemic taking prednisone or steroids. So keep that in mind. And then the bisphosphonates, if you have osteoporosis and they want to give you a bisphosphonate for that, it may cause hypocalcemia, and particularly if it's an IV bisphosphonate, okay? And then the proton pump inhibitors, you can get both a low magnesium and a low calcium from them because they change the acid in the stomach and they change the absorption of these very important calcium and magnesium. And then chemotherapy. If you're about to get chemotherapy, say, hey, wait a minute, I have hypopara, I'm taking calcium and magnesium and so forth. And the doctor needs to monitor your hypopara more carefully if you're getting chemotherapy. Like I said, many of you take thyroid hormone, so there's even a longer list of medicines that affect the absorption of thyroid hormone or thyroxine. Again, the proton pump inhibitors, iron in multivitamins or just iron by itself, okay? The H2 blockers like ranitidine can affect the absorption of calcium. Antacids, sometimes people are using these bile acid binding resins, for cholesterol. Sometimes they're using phosphate binders. That's going to have an effect. Raloxifene can have an effect. Sulfate. And then disease. So these are some of the drugs, the important drugs that can alter the absorption of thyroxine. And I've highlighted calcium because it can bind it and you're not going to get any thyroxine absorbed. Then diseases, anything that affects the intestine or surgery on the intestine can affect thyroxine absorption. And then foods, and I think this is something we don't always realize. Coffee can affect the absorption of thyroxine. So when you're taking your thyroxine in the morning, don't take it with coffee, take it with plain water, espresso particularly, okay? And then cereals, the fiber in cereals can alter the absorption, and then the citrus juices and other foods. So you want to take that thyroxine if you possibly can on an empty stomach with plain water. So my final sort of piece of advice is kind of, prepare for your appointments. You're only going to get as much out of these appointments as much as you're prepared. So bring a medication list with you. And that is a must for the ER. Don't let them guess because you're the one who's going to know what you've been taking and when you made the changes. So bring that medication list. When you come to the office, if the meds changed, write down on your calendar or your phone or something when you made that change, okay? And then if you're on new prescription drugs from somebody else, or you started a new over-the-counter supplement, bring them in or take a picture and bring it with you so that, we know what you're taking and whether there's any issue for interaction. And then I say, when you're due for lab tests, get them before the appointment. I was so happy on Wednesday. A mom brought her 2 daughters and they had gotten their lab test that morning. So everything we looked at, they both had hypopara. Everything we looked at was like 2 hours old. It was wonderful. We knew exactly what was going on, how they felt, and what their lab tests looked like. So it's wonderful. And then if you're due for an ultrasound, get it before the appointment, okay? So we have everything we can talk about. And the same with the 24-hour urine. Don't wait till after the appointment, do it before the appointment. So again, we can talk about what's going on right now in real time. And then I talked about symptoms, and I think, we want to know, is what we're doing, is the treatment plan working? Are your symptoms controlled? I mean, only you can tell us that. So bring your calendar in with any symptoms you have logged in, because you can't remember when you're sitting there. Was it Tuesday? Was it Wednesday? Was it last month? Was it this month? Bring your calendar. And if you go to the ER often, make sure you tell your doctor, excuse me, and make sure there's a plan in that ER for your acute treatment, and your doctor can set that up. And then sign a release when you're there to get the records sent to your doctor so they know what happened. Honestly, that will make you a hero. If you took care of that, and then your doctor knows, hey, you were in the ER last week, here's what they did, here's what your numbers were, and you're having your appointment. It's so helpful. I can't tell you how helpful it is. And then I've already said, track the lab tests along with the meds and the supplements. Really, really important. So just some final tips: take the meds regularly, take them on schedule. Don't do, crazy things with the schedule. Spread out the calcium to maximize its absorption. Remember, 500 milligrams is all your body can handle at any one time. Take your thyroid on an empty stomach and wait an hour before you eat. Fast, if at all possible. And iron, calcium, and vitamins, take them away from the thyroid hormone. Don't do the same. Don't take them at the same time or even close by, 2 to 3 hours if you can separate them. Calcium fortified orange juice can affect thyroid hormone absorption, as can fiber, coffee, and espresso, and the same with antacids and multivitamins. So remember, probably thyroid is a little bit more finicky to take than even the stuff we do for hypopara. But keep that all in mind, because I know many of you are taking both types of medicines. So with that, I'm going to just close. The final tips are: check what, if we prescribe something and the pharmacist dispenses something, just make sure it's right, particularly with the thyroid. Like if you've taken Synthroid for 20 years and all of a sudden they've got another one there, say, hey, I don't want that. I want what I've been taking. Okay. Because that's going to affect, you might become hypothyroid and you might feel poorly, and that's you who's got to deal with those consequences. So stay with the same brand, bring your questions to the appointment, bring in your new meds and supplements. And then this is an important point. If you need it, if you're going to the ER and your hypopara is hard to control, wear a medical alert bracelet so that the doctors who see you or someone in the field who finds you knows what your condition is. So wear that medical alert bracelet. And yep, we're in this together. We want you to feel your best. So with that, I will stop sharing and be happy to take some questions.
Thank you, Dr. Shoback. There was a comment, and it was just how this has been the most informative talk that they've ever heard. So thank you. There are a lot of questions, and I will try to answer as many as I can. Jill wants to know, if you are managed well on PTH injections and not taking any calcium or calcitriol, what should you be doing? Should you be doing an annual 24-hour urine test?
I think so. I think that I take your point, Jill. You're not doing calcium, you're not doing calcitriol. Sometimes diet changes, whatever. I think I'd get a baseline, and then maybe if it really is like uninteresting, it's really normal and you don't have any kidney stones and all that, maybe you don't have to do it for 2, 3, 4 years. But I think periodically it's not a bad thing to check.
Okay. Let's see. Are repeated soft tissue injuries directly related to hypopara and or its treatment? Do phosphorus levels have an impact on this?
I don't think we know the answer to that. Like if you have injuries to soft tissue, do calcium and phosphate deposits occur in those tissues? In some situations, they are the sign of injury, but I'm not so sure about like if you fall and you hit a muscle, you would get I don't think you'd get a deposit there. I'm going to take a stab at that one. I don't think you'd get a deposit there. Certain conditions, yes. And if the product is really high, maybe. Like if that product is 60 or 70 and we don't want it to be there, maybe yes, under circumstances where the product might be very high. But I don't think hypopara by itself is causing that kind of thing.
Okay. Jean's asking, how does hypopara cause an increase in creatinine and a decrease in EGFR? And how can one improve the EGFR?
Boy, I would be, if I could figure that one out, I would be a very, very smart person. So when the creatinine rises, the estimated GFR goes down. They kind of go in an inverse direction, okay? So they're always going to be inverse of each other. So when your creatinine gets high, it means you're not clearing creatinine, that's a muscle product, out of the body, okay? So the levels go up because you're not clearing it. And that is a reflection of the fact that your kidney isn't working. How can we get the kidney to work better? Basically, I would say control all the risk factors you can control. If you have high blood pressure, get that under beautiful control, okay? If you're eating too much salt and your blood pressure is high, get that down, okay? If you have diabetes and your diabetes is out of control, get that under control. As I know it's not easy. It's easy to say, but hard to do. Try to do that. And then, it becomes tricky. If your creatinine is high and your estimated GFR is low, talk to a nephrologist. Ask for a kidney referral. The kidney specialist is called the nephrologist, and I would ask for that. I often send my hypopara because maybe the kidney specialist will look and say, hey, that blood pressure needs to be a little better controlled. I want it to be in this range. Okay, perfect. That was a good referral. So I'd ask for that referral.
What do you do with a patient who with treatment is presenting normal labs, but is still showing symptoms like muscle weakness, tachycardia, etc.?
Yeah, this happens more often than I like to admit. I think that, normal labs at one moment in time are just that, normal labs at one moment in time. There may be excursions. So what I do then is, and the other part of it is that, if your calcium was low at one point, maybe you had a bunch of tetany during the night and muscle cramps or something like that. Those muscles don't snap back in an instant. They may feel weak and sore and tired the next day. And that might be the problem, So I think you have to kind of know what's the trajectory been, what's the history been. Have there been a lot of symptoms? If somebody's completely without symptoms or without a low calcium ever, but has muscle weakness, I would say, okay, is the thyroid normal? Is there another reason? Because if the blood tests are like normal, 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 never deviate from normal, I don't want to lay that at the doorstep of hypopara. I'm wondering, like I said, fatigue, there's 100 causes for it. Same with muscle weakness. There's not just one cause. It's not just hypopara. Could be thyroid, could be, other muscle problems. I would, ask, your internist or your pediatrician or whomever's taking care of the patient, could this be something else? My hypopara is okay. Have that kind of discussion.
Thank you. Someone wants to know, what is your opinion of calcium lactate versus carbonate and citrate?
Yes, nothing that I know of that's wrong with calcium lactate. It's just that the amount of calcium is really tiny. I think the citrate is, only 21%, and I believe the lactate's even lower than that. So you've got to take more of it in order, a lot more tablets in order to get to, like, let's say you're taking, like I was saying, 500 milligrams of elemental calcium 3 times a day. That's 1,500 milligrams of calcium. Well, with the typical calcium citrate tablet, Okay, with calcium carbonate, you can take 3 tablets. And I think most of us can swallow 3 tablets of calcium carbonate. Okay, for the citrate, if you get the 250 milligram tablet, right there, let me do the arithmetic, you got 6 tablets. Can you swallow 6? With the lactate, you might even have to take more. So that's why I didn't present it as a great option. Less known about it in hypopara, because when we use carbonate or citrate, we know those are the common ones. Most of the studies are going to be people taking those, and we can kind of generalize from that. But the lactate isn't used as much. If it's working for you, I'm not against it.
Okay. Kathy wants to know if food has both calcium and phosphorus, does the calcium bind with the phosphorus?
There sometimes is binding in the food itself when it's coming in. It kind of depends on how much phosphorus is there, how much calcium is there, the relative speed at which things move through the intestine. Is way more complicated than the parathyroid hormone, but yes, there is sometimes binding, and we use, like sometimes this is counterintuitive. Sometimes patients who have kidney stones, we give them calcium. You're like, oh no, is that going to cause a stone? Well, it'll bind up something like oxalate and get rid of that and help with the kidney stones. So we do use calcium as a phosphate binder and as an oxalate binder in circumstances. So that might be important in some people's situations.
Okay, now Kimberly has 2 questions. One, if you are on a PTH hormone like Forteo, do you still need to take calcitriol? And she also wants to know if a patient cannot tolerate magnesium supplements, what options do they have?
Yeah, so if you're on PTH, you often can come completely off calcitriol, because if you remember back to that first lecture, one of the important jobs of PTH is to make 25 go to 125 in our bodies. So if you've got enough PTH coming in, your own kidney can make its 125. So you often don't need it. So the answer to that question is you probably don't need calcitriol. And if you need any, you might need just a little tiny bit. Okay, so if you don't like magnesium supplements because, I don't know, the taste, or sometimes they cause diarrhea and so forth, and it's not the best situation, just a regular diet. I don't know. It's a good question. And I'll look it up for the next time. I don't know what foods are particularly high in magnesium. I don't know. Maybe Lynn can answer that, whereas I can't. I can't direct you to a certain kind of food you can substitute for magnesium oxide, but I would say have a regular balanced diet, which isn't much help. But if you're talking to a nutritionist, that person probably knows more than I do about magnesium in the food.
Okay, and if you do take calcitriol, do you need to take D2 or D3?
Good question. I think so, and I'll tell you why. But it's a little bit argued. Some doctors don't believe what I just said. But the reason that I think you need to take it is you want to make sure the tank is full. You don't need to have a lot of it there. Just fill the tank, because all the different cells in our body make their own 125 vitamin D. Of course, when it's coming in through you're taking it as calcitriol, you could say, well, there's plenty coming in. And that's true, except we don't know. We're not as smart as the body. We don't know whether the T cell or the heart wants to have a certain level right inside that cell that it makes itself. So I always say, at least start with a full tank. Take a little bit to get the level to a sufficient level, and then continue your calcitriol on top of that.
Okay, one more about calcium. Does calcium citrate rather than calcium carbonate cause citrate to change in the urine? I take potassium citrate because of my kidneys, and that was asked by Cole.
Yeah. So the the studies with kidney stones and the prevention of kidney stone formation with potassium citrate, that is, in general, the salt that has been used in the studies. So that's what's been done. And I don't know why necessarily that was selected, but the amount of citrate in the potassium citrate tablet is, I guess, the right amount to achieve the suppression of kidney stone formation. The calcium citrate that you take with hypopara certainly can provide some citrate to reduce the kidney stone formation, but the sort of studies and the dosing has all been set up with potassium citrate for kidney stones. So that's what we tend to use. We tend to not, pile on thousands of milligrams of calcium citrate in order to get kidney stone reduction. We use the K-citrate.
Okay, we're just going to ask one or two more questions. Jennifer wants to know, does a high fiber diet prevent calcium absorption?
I have not seen anything that suggests that. I guess the type of fiber, it's a good question, Jennifer. I guess the type of, I'll try to get the answer for that for the next time. I guess the type of fiber would matter. I know we are doing studies to try to actually use fiber to help people absorb calcium better, but a lot of those are individuals who've had like surgery, like gastric bypass surgery and so forth. But in the normal person without any surgery, fiber, I don't have a good answer to that.
Okay, and Roger wants to know, he's on long-term use of prednisone and how does that affect him?
Yeah. Okay, so there's a lot of effects of prednisone, and let's just focus on the bone and mineral system. So number one, it can cause loss of bone mass and it can cause osteoporosis. So long-term prednisone, if it's at a dose above about 5 to 7.5 milligrams per day, bone density should be looked at. This would be a situation, how I kind of said, oh, you don't need a DEXA every year, don't ask for that because it's generally not needed. Here's a situation where you do want to watch the DEXA scan, okay, prednisone. Okay, so that's one thing, bone demineralization. The second thing is prednisone and steroids can act on the intestine to kind of interrupt the ability of vitamin D to work. So if you're on it chronically, your doctor's probably already made adjustments, but if you're getting it started, I've had patients with hypopara start prednisone. One day that everything was fine, the calcium was completely normal. A week later of prednisone, it was 6 milligrams. You're like, what happened? Prednisone. So keep that in mind if someone's starting that on you, because your calcium can definitely fall. And those are really the main things. Sometimes the calcium in the urine goes pretty high on prednisone, depending on the dose. So those are all things that need to be watched by whoever's taking care of you for your hypopara. And you need to tell them, I have hypopara. This could affect me. When do I need to get this monitored? I want to get this checked.
And one last question here. Does collagen affect absorption of calcium at all?
Oh gosh, I don't know. I don't know the answer to that at all. You guys are stumping me again today.
We have some smart patients here.
I know you certainly do. My gosh, fiber, collagen. I've gotten some good questions. I don't know the answer to. I don't know the answer to that. What I would say is, if you're taking a supplement, like I said, bring it with you. So whoever's taking care, you can look at what's on the label, okay? And then if you're taking it every day and your blood tests are okay, that's not a very scientific answer, but probably things are okay. It's probably not blocking anything. Common sense sometimes have to use, because we don't have information on a lot of supplements. People ask me all kinds of questions about supplements. It's like, they're not drugs. They don't have to do the kind of testing we have to do for drugs. So we may not know the answer to your good question.
Okay, and just one
Dr.
more.
Oh, sorry, Barry.
Sorry, I was just going to ask, someone wanted to know about steroid injections for their back. Does that affect their vitamin D absorption? That was from Justin. Sorry, Michelle.
Another really good question. And I don't even know that there's information on it, but for hypopara, but I can tell you that steroid injections to the back, like for example, if you have diabetes, there are several patients with, maybe not everybody, but a fair number of people with diabetes who get those injections whose blood sugar goes up because some of it is absorbed into the circulation. So potentially, yes. But again, if your levels are okay, probably it's not doing that particular, negative effect of steroid.
Well, thank you, Dr. Shoback. I'm sure we could probably have another hour worth of questions for you, but sadly we're going to have to end, and we will try to get to you any questions that were not asked. And I apologize to those who I couldn't answer your questions or have Dr. Shoback answer your questions.
Okay, actually, Barry, I'm going to ask one more question that the whole board over here was curious about. And then, are you there, Dr. Shoback?
Yep.
I'm going to ask one more question. And then for the attendees, I have a couple of announcements to make. But the board is wondering, is there a risk of vitamin D buildup because we take so much vitamin D? And how would we know if we were getting too much?
Yeah, sure. The risks of vitamin D buildup, if we're talking about regular vitamin D2 and vitamin D3, we measure the level. We measure the 25-hydroxy D level. And generally, we don't want it to get high. We want it to stay in that normal range, not high. And we think that that's safe. And about 11 years ago now, the Institute of Medicine covering the US and Canada told us, you guys are okay if you're taking up to about 4,000 a day. So generally people are not taking more than that. So we think it's safe. And they did a thorough review of the literature for toxicity. So I feel like we know that pretty well. Now, if you're taking too much calcitriol and the calcium level goes high and the phosphorus level goes high, then you have the negative effect of calcium and phosphate precipitating in the tissues. Not the vitamin D itself. It's not sitting in a muscle or in the heart causing a problem that we know of. It's that calcium and phosphorus from that high product that can cause, organ dysfunction.
We appreciate that, Dr. Shoback. Thank you. Okay, attendees, we are going to take a short break. I also want to let you know that Dr. Shoback's slides are already up on the event website. Just go under documents on the left-hand side and you will be able to see those, look at them, use them for your personal use. And the videos, again, we've had a lot of questions coming in about the videos. The videos will be posted after the conference is over. We need time to, download them, convert the files and get them, prepped for you guys to see. So on that note, we are all set and we will see you guys again in about 15, 20 minutes.
Thank you.
Thank you.